The content herein is for informational purposes only, not intended as medical advice, diagnosis, or treatment, and is not to be substituted for direct advice from your doctor.
Today's LymphCast program is proudly sponsored by VitaSupport MD, the makers of Vein Formula 1000 and Lymphatic Formula 1000. These MPFF-based nutraceuticals are backed by science and recommended by doctors specializing in venous and lymphatic disorders. Visit VitaSupportMD.com to learn more.
Greetings and welcome to our LymphCast show, episode 52 tonight. We really appreciate you being with us. As a reminder, every episode is in podcast land. Wherever you go for your podcast, just type in LymphCast. This show will come up. Every show is also on YouTube, so you can find out what we actually look like when we're on screen. We invite you to join us there as well. If you have a question or a comment for the doctors, please email it to hello@lymphcastnetwork.com and visit our website early and often, lymphcastnetwork.com. Let's go around the table and meet the panel tonight. From California, a regular panelist. Nice to have her back. She was gone for a couple of episodes. Dr. Monica Glavitsky, actually from Arizona. I put you in the wrong state. Welcome, Dr. Glavitsky. It's good to have you here.
Thank you. I'm so happy to be back after these several sessions that were, conflicting with my traveling. But here I am. And right. For what distinguished guests. Wonderful.
You were gone so long, we moved your house to California. I forgot to tell you about that. Sorry about that. The gentleman who started this show with a seed of an idea and built it into this big, great, terrific show, episode 52. He's also the founder and owner of VitaSupport MD. They make Vein Formula 1000 and Lymphatic Formula 1000 from New Jersey. Physician, surgeon, Dr. John A. Chubak. Hello, Dr. Chubak. How are you?
Hi, Paul. I'm doing well. Great to see you again. Looking forward to a great show tonight.
Absolutely. We even have a slideshow tonight. We're going all the way. So I'll turn it back to you. You bring in our special guest and off we go.
Great. Well, ladies and gentlemen, tonight we have a very special guest, somebody who's become a personal friend of mine in the last year or so, Dr. Andrew Wickline. Andrew is an esteemed colleague and orthopedic surgeon practicing in upstate New York. He's a graduate of the 7-year medical program at Union College, which is a renowned and very historical college here in the Northeast of the United States, with a great history and reputation. If I'm not mistaken, there's been some American presidents who have graduated from that college. And then he went on to do his medical training at Albany in the state capitol in New York, and his orthopedic surgical residency there as well, and then went on to do a fellowship at the Cleveland Clinic. And since he's been very, very active, both clinically with an extremely successful and high volume clinical practice, but as a private practitioner and clinician, has set himself apart to a great extent in the sense that he remains very academically oriented and interested in research and best practices and so on and so forth. And I know one of the things that we'll discuss tonight, and a big part of the reason that Dr. Wickline is with us on the show, is because of his great interest in the importance of post-operative edema in patients, particularly after total joint replacements in the orthopedic surgical world. So, Dr. Wickline, welcome and thank you for making the time to be here tonight.
Well, very honored to be here. I never really, I hate to say it, I'm a little embarrassed to say it. We've always been told after joint replacement, that swelling is normal and, patient just has to deal with it. And, when I had my family member had cancer, all of a sudden we had to worry about, large lymph node dissection and lymphedema. And I suddenly had to go back to some textbooks that I had long forgotten and identify, what is lymphedema and how do we actually manage it and what can I do to help my family? And, separately, we're kind of down this path for joint replacements. Back in 2013, we stopped doing the standard aggressive physical therapy because I was seeing that patients were swelling too much they were crying in therapy. They were really suffering. And so we were able to help mitigate some of that swelling. And so the combination of what I was already working on and then having a family member specifically have a problem and potential issue with lymphedema, kind of it had the two pathways merged, and it really led me down this path was to meet some remarkable individuals, yourself, Mark Mellon, Malene rather, Suzanne Emin, some of these CLT. I didn't even know what that meant until you have a family member that has this problem. And so we were fortunate enough to write a multidisciplinary paper about mitigating the total knee tsunami, the swelling that occurs. And again, with not just one orthopedic surgeon, I was kind of the new kid on the block. Everyone else knows this is a problem. It's just the orthopedic surgeons are just unaware that there's stuff we can do. So again, I want to thank you for and thank the audience for listening to this, because there's so much we can do with post-operative and pre-operative swelling and how we can treat those patients and get better outcomes. I'm lucky to have really some of the lowest complication rates and 90-day costs in the country. And it's really because it's the management of all the other pieces, not just that 1 hour in the surgical room. There's basically 3,000 hours involved in a patient's recovery, and we need to be focusing on the entire recovery. So anyhow, as you can see, I've got my mother's gift of gab. So we can either start with a few slides, or why don't you have a couple questions for me, or you take it from here.
I think it would be good to start with your slides, because my understanding is that you developed the whole theory how important is the treatment of pre- and post-operative edema treatment, right?
Okay. So I'll go over some of the slides. These are slides from, we were recently asked to speak at the Connecticut Orthopedic Society. So these are slides, some of these slides are from that meeting. So, stop me as we go. But I think there's some really compelling information here. So let me go ahead and do the share screen. And here we go. And hit share. And are you able to see the screen?
Wonderful, yes.
Perfect. So this is a graphic directly from our paper, which is actually anyone can find. It's in the Journal of Orthopedic Experience and Innovation, Mitigating the Total Knee Tsunami. So if you go to Journal of Orthopedic Experience and Innovation, look up tsunami, and you will find the article. No one else has that word in the title, and it's free, public access, free worldwide. So please, I encourage you to look at that because my colleagues and I really spent a lot of time on it. And this graphic really talks about how you can see the total knee is this procedure way out here somewhere in the ocean, and no one really sees it because it's behind closed doors in the operating room. But that trauma, that seismic event out on the ocean floor leads to trauma, pain, inflammation, and then you get this increased vascular permeability and cellular hypoxia, leading to, of course, blood clot risk, altered gait, fall risk, and then sometimes ankylosis, dehiscence, and infection. So again, this is the kind of the wave that the patient potentially sees, all from that little seismic event that we, as orthopedic surgeons, just that 1 hour in the operating room. And so, again, we know that increased interstitial fluid creates a problem. You guys work closely in the wound, the chronic wound world. And what do we do for non-healing ulcers, right? We know that they have faster healing if we just get that edema out of the leg. And so we need to be focusing on that as orthopedic surgeons. If we get that edema out of the leg, we may have less wound healing problems and less infection risk, right? And we know that the patients don't like it. In fact, you don't like swelling. If you bite your lip, you notice it every day until the swelling goes away. And so, if we want patients to have a forgotten knee, a knee that's almost like their own, we have to control the swelling. If the swelling is not controlled, they're going to think about it every single day. And these are the things patients say about it. It feels tight. Hey, doc, there's like a vice around my knee. Is that ever going to go away? And then we also know from the physical therapy literature that swelling leads to muscle inhibition. So the quad wants to stop firing, and then the knee kind of gives way. And lastly, we know that fluid does not compress. So the greater the swelling, the lower the range of motion. And this factoid really is the one that really surprised me. My total knee is the number 2 cause of worsening lower leg lymphedema after cancer. So I did not realize that I'm potentially a culprit in patients having these problems. So I don't know, John, were you aware of that?
I wasn't, but it doesn't come as a huge surprise having, rotated on orthopedic surgery as a resident and then even in practice, having had the opportunity to help out some colleagues when they really needed a hand in the OR and needed an assistant. It is, it's a major operation and maximally sort of invasive, and there's a lot of tissue disruption. You're going through the skin and mobilizing the patella, and then doing major arthroplasty on the joint and placing that prosthesis, and it does take some time, and the leg is heavily manipulated and mobilized, and so it's a traumatic operation. There's no question about it. So it really doesn't come as a huge surprise.
And in addition,
so and I have a question: is that because of the tissue disruption and the global trauma to the whole knee region, or there is a specific additional damage to the lymphatics?
So certainly, there's the trauma itself, right, that disrupts some of the dermal lymphatics. And then many of us still use a tourniquet. I have stopped using a tourniquet since 2017. Unfortunately, a lot of my colleagues, they write papers that say that doesn't make a difference. So I definitely am looking for someone in the chronic wound world that could help us maybe do some of those infrared imaging studies to show the damage from the tourniquet, or try to image the ventromedial bundle pre and post tourniquet application, because I personally think there's likely, if not temporary, potentially permanent damage to the ventromedial bundle. So you knock out, the major highways in California with the 6 lanes of highways, right? You knock that out, that means all that traffic has to go back on the back roads. It's the same thing with the leg. You take out the ventromedial bundle, now all that fluid has to somehow get back to the central, the core, and how's it going to do that? And that's where patients have this big, tight, swollen leg. And so I think tourniquet in itself is a problem. And then lastly, we tell patients, hey, you need to go tomorrow, you got to go out to outpatient therapy and do a 90-minute workout on that new knee. So, and it's kind of crazy, right? If you sprain your ankle badly, you certainly wouldn't walk 90 minutes the next day to make it heal faster. But unfortunately, that's kind of the way our system has been set up, and we're afraid to change.
Yeah, and I would say just anatomically and pathophysiologically, in addition to the ventromedial bundle, with a tourniquet applied for that period of time and at that pressure, required to give hemostasis, you're also going to have significant venous hypertension. You're going to have obstruction of venous return, venous hypertension. And then, of course, that's going to lead to increased capillary permeability distally and forced fluid, extracellular fluid into the interstitium, into the third space. And that, of course, incites that entire inflammatory cascade that we know is going to follow from that kind of transient injury. The other thing that we know, and I'll just comment on that and we'll get back to your slides, which I have found so fascinating in our discussions, and I think Monica would agree with this. This is a really important subject about this tourniquet because we've had many guests on the show now who are lymphedema sufferers who didn't have lymphedema in their entire life and then sustained a minor trauma like a twisted ankle, not even a bad severe sprain, just a twisted ankle or an insect bite. And those traumatic experiences were enough to tip certain individuals over who may have been sort of hypoplastic in their lymphatic development embryologically and congenitally. So there is this subgroup of patients who are probably walking around with a less well-developed lymphatic system in the lower extremity who've never shown any sign of that. But this kind of, relatively minor trauma can be that thing that that tips them over. And it's part of the explanation that we as surgeons always wonder, well, why do I do this every single day? And I never have this problem. And then 1 in 100 cases, here's this patient who winds up with, not a transiently swollen, but a chronically swollen limb. So I think that's one of the things that we've kind of uncovered in this program, just sort of clinically, empirically from hearing people's stories, that sometimes minor trauma is the inciting event for people who are kind of on the borderline in terms of their lymphatic circulation, in terms of its development. So those are just a few ideas.
So I'm going to show you some slides now. This is a different study we published, again, also open access. We're looking at different options. I've done some research prior to this and showing that our swelling was lower than the national average. And so then we used a new product that's bactericidal, but also has some anti-inflammatory effects. And so this is during this data collection set, we were able to correlate, I think for the first time, I'm not aware of any other published article, but it certainly could be out there, that as swelling increases, so does opioid usage. Again, intuitively, we know that makes sense. You got a big swollen ankle, it hurts. You're probably going to be more likely to take some sort of pain medication. But here we could show in joint replacements specifically that as swelling increased, the inflammatory numbers increases measured via bioimpedance assessment, that the opioid use increased. Additionally, as the swelling increased, so did the device usage. So again, makes sense. You've got a swollen joint, just like that graphic earlier. Swelling leads to altered gait pattern and increased fall risk. So these patients they feel that. It feels funny. It doesn't feel right. And so they use a walker and a cane longer. And then again, through that study, we were able to show that as swelling increases, of course, range of motion decreases. And this is especially important for joint replacement, right? You need 120 degrees ideally to have a happy joint replacement. And the less than 50% of the nation gets 110 degrees or less. Go ahead.
Sorry, I have a question.
Yes, please.
So because on your slide you have the percent of inflammation. What was exactly the measure?
So again, that's using bioimpedance assessment. So that's
okay.
Yes.
Okay.
Like two little electrodes, one on the thigh, one on the shin, and this is after the reference paper, which was published by Doctor of Physical Therapy, Dr. Brian Lloyd, LOID, in Disability and Rehabilitation 2020. That's a great article and really shows the different reference curves, and we're going to talk about that a little bit later through the slides. But again, that we use the same measurement technique, and we can discuss. I've got some slides on different ways to measure. Currently, I think it's the gold standard because it's reproducible and it's fairly economical. But again, over half the country gets less than 110 degrees because they get too swollen with joint replacement. And then while they're swollen, the blood that's in there turns to scar tissue, and they end up with a less than ideal result. So, and we now have data to show why that happens. Or potentially, I can't say that specifically that's why it happens, but certainly it makes sense. So again, how do we measure swelling? These are all the different ways. We're right now evaluating a dermal microwave assessment. We've tried 3D optical scanning. It's pretty interesting, but really challenging to always have the same volumetric assessment. I trialed the bioimpedance spectroscopy. We had trouble with that. Patients weren't putting full weight on their operative leg early on, so the data points were not amazing. And then, of course, serum biomarkers are another great way to do it, but these patients are all going home same day, and so that's a super challenging and expensive way to measure. So again, this is, I apologize, this is, I was not able to get the access and the approval to use this specific chart. So if you look at the chart directly from Brian Lloyd's paper, basically it shows on day 7 is when maximum leg swelling happens after knee replacement. Not day 1, not day 2, but day 7, with a range between 22 and 46% more fluid in the leg, and the mean being a 34% more swelling 7 days after surgery. So that's substantial. And again, it kind of corresponds to when patients call the office and say, suddenly I can't put any weight on the leg, and this is so painful. Now we have at least a reason for it. So again, I think patients really want no swelling, and I think that's something we should be focusing on. And we know that across the nation, somewhere between 15 to 20% of patients are not wholly satisfied with their joint replacement, and no one really has a good answer. And I'm thinking that maybe it's due to swelling. I can't prove that yet, but certainly none of the other things we've identified has seemed to have made a difference. And so I really think we should be focusing on the other 3,000 hours of the patient's recovery. Mm-hmm. And then if we measure and mitigate that swelling, we'll find out. Maybe it's not the answer. But at the end of the day, like we talked about before, no one likes a swollen joint. I see Emily's also joined us, and you're welcome to ask questions as well, Emily. And then John, just to, again, stop me when my gift of gab is getting to be too long-winded.
No, it's perfect.
No, that's super.
Okay,
that makes perfect sense.
I do have one question as a non-orthopedic surgeon, and this, I have some ideas about what the answer might be, but I don't know. In terms of the range of motion, are patients generally tested for range of motion preoperatively, or would that be a waste of time because the joint needs to be replaced and they have limited range of motion, or is that in any way a predictor of post-operative?
Certainly patients who have poor motion, the rule of thumb has always been whatever you start with is kind of what you get, right? And we try to do better than that. Intraoperatively, we get them to a better number. But you're right, if they're starting at 15 to 85 degrees, I'm hoping I can get them to 5 to 120, or maybe even 0 to 120. And the question is, can I keep that for them? Will the patient work hard enough to overcome the inflexibility of the quad and the hamstrings? But frequently we're able to. So, but you're right. Some patients do come to the table with an additional set of problems. But in and of itself, the swelling, I think, is overall a big one, right? You can't compress a fluid.
Yeah, and then another issue or concern that you're bringing to light with the work that you're doing, I think, is swelling, preoperative swelling. Right. I mean, that's a major challenge, right? I mean, as a vascular specialist focused on veins, I have a fair number of orthopedists in my area who send patients for venous procedures, surgery, endovenous ablation, et cetera, prior to surgery, usually because they have large prepatellar varicosities, and they're concerned about cutting through these huge varicose veins. But one of the things that I've actually discussed with them over the years is I'm glad you sent them, but there's a second added benefit here. I think the limb is going to be much less swollen. So that's another consideration that I think probably historically hasn't gotten enough exposure, and I think you're bringing light to that as well.
100%. I've never been to a lecture in my 28 years of residency, fellowship, and clinical practice where there's been a discussion about this, not once. So again, the reality is there's no money in it, right? So we get a fee, a very meager fee at this point for joint replacement, and that includes 90 days of care. So after you pay all your overhead, you're looking at like $150 from a Medicare reimbursement. So I think there's really no incentive to make changes.
Do more.
Yeah.
Well, I think also the issue is that all this vascular problematic and the problematic of lymphedema and edema, actually it's gaining the awareness right now, last decade. And I remember from my schools, that was practically close to zero time devoted to venous and lymphatic system. So that's not surprising.
100%. It was kind of like an afterthought discussion,
And the other thing that you pointed out about the financial aspect of it is that, people, the surgeons historically haven't really been concerned because they're going to do their operation. They're going to get paid whatever the reimbursement is. As you said, unfortunately, it's declining and decreasing rapidly. But when you have a complication, it has a major impact on the healthcare system overall. And as you pointed out in your early remarks, you're finding that it's decreasing the cost of the overall experience and surgical kind of journey when the patients don't have these complications as wound problems and infections and dehiscence and so on and so forth. And it reminds me a little bit, Monica, of some of the data you've shared over the years regarding MPFF in certain instances with wound care, venous leg ulcer, that the addition of MPFF, for example, has actually decreased the overall cost of care because you have a more rapid course to total healing. So these additions that you're making and these protocols that you're building, Andrew, I think that the clinician may not be so worried about the overall cost, but the federal government and the insurers certainly should be, because it's those complications that add massively to cost.
Correct.
Absolutely. And in the case of venous ulcers, actually it's the decrease by 45% of cost of ulcer treatment using just the adjunctive MPFF with, of course, the compression therapy and wound care.
That's amazing. It's dramatic.
Yeah.
Vein Formula 1000 and Lymphatic Formula 1000 from Vita Support MD are backed by science and sold in doctors' offices. If you're a physician who may be interested in prescribing or selling these excellent nutraceuticals, please call 862-246-7877 to speak to a representative today.
So I always like to ask my audience, does a farmer plant seeds? Which field does the farmer plant the seeds in? Is it the one on the left or the one on the right? And I think we all know you put the seeds over on the left, those seeds are going to rot. They're certainly not going to germinate well. They're going to struggle to survive versus the right. And so I would ask, and this is the next question, everyone knows the answer. I say, well, should we put plant a new knee in a flooded leg? You can see this picture here. You can see it's not not severely lymphodematous, but there's certainly a difference, isn't there? And this is right out of our own journals, Yellow Journal, in 2020. This pre-op lymphedema increases the revision risk, reoperation risk, infection, periprosthetic fracture, and tibial component loosening. So the answer is no, we should not plant a new knee in a flooded leg. We should do something about it. But again, many of my colleagues, well, what do I do? And I don't really know what to do for these patients. Put them in a stocking. And so Mark and Susie and Frank and Wendy Cole, again, my co-authors on that mitigating the post-operative swelling tsunami, we kind of came up with our own guidelines. These are not proven yet, but I think these are the things that intuitively make sense. So if you're a grade 0, again, if patients have no pitting edema, varicosities, they've never had vein surgery, they've never seen John in his clinic, they don't have any hemosiderin, then grade 0, no signs present, anti-inflammatory, low salt, less than 1,500 milligram diet, daily exercise, lymphatic exercise, not this crazy trying to strengthen the leg, but really exercise that improves lymphatics, and strongly consider bioflavonoids. Grade 1 is one sign and or pitting edema, grade 1 or 2 grades. And then that person should definitely do everything in grade 0, the diet and salt and exercise, but add the MPFFs and get into a compression stocking. They should have their protein levels checked and treated if they're low. In total joint land, low albumin is the #1 cause for complications. And then also, if they're on amlodipine, we should try to get them switched. That's been well known to cause significant lower leg swelling. And then you can see that yellow is a grade, grade 1 is yellow, right? Just like the green light is go, yellow is, caution. And then grade 2, one or more signs with pitting edema of 3 or 4. And that's where the surgery should be stopped. No elective surgery for this patient. We need to get them down to the yellow zone at least. And that's where they should see a CLT. I think the CLTs in most communities are the ones probably best and most interested in this. When the wound clinic, it's challenging to get patients in. There's just never enough wound surgeons available and physicians available. So I think the CLT is probably the best answer for most orthopedic practices. So again, this is what I think we should be doing for preoperative workup and a plan. Any thoughts?
I commend you for this wonderful approach, because it's truly like almost revolutionary. Is certainly well done. I think that indeed, and especially for, as you said, for grade 2 patients with the clear issue that the veins or lymphatic you need a vascular specialist help before the jumping and operating on the knee. Just wanted to correct a little thing. I know I'm a perfectionist. It's MEFF without S, because it's micronized purified flavonoid fraction.
Okay,
there is no S. Okay.
Okay, thank you.
You're welcome.
I know where he got that from, our dear friend Mark Moline.
Yeah.
Mark likes to always add an S, so we know it's not your fault, Andrew. Emily, can you hear us?
Fantastic lecture. And I really love the approach of a pre-surgical intervention and thorough examination. Recently, I had quite a few patients who had prostatectomy years ago, and maybe they forgot to tell the surgeon about that. And so after total knee replacement, they did not heal well, or they started to have more swelling in the lower extremity. And then we found out, 20 years ago, you had surgery and you had radiation treatments. Of course, you are not going to heal so well. And so I think that should be part of the history evaluation, and also pre-surgical evaluation if there was any kind of a surgical intervention or radiation treatments to the pelvic area. And today I had interesting patient. The patient is a well-known 69-year-old man who had just total knee replacement on the right, and 2 weeks later, he came back with such a massive hematoma in the leg. So first thing is, of course, I checked if he had any kind of incident with the veins. And fortunately, he did not have any DVT. So it was just the hematoma. And again, when he went for follow-up, they said, oh, that's okay. You're going to be fine. The swelling will heal soon. So this kind of treatments, the same thing over and over, I see that the patients are given furosemide, and if it doesn't work with 20 milligrams, so go to 40 milligrams and so on. And what is interesting is pretty much all the post-surgical patients are getting the TED hoses, one size fits all white compression stockings. They don't fit well at all, and they may induce more swelling. And so it's
more trauma sometimes, because you have some the issue with the stockings that are not fit the patients.
Absolutely.
Yeah, and that's where you'll see in this, we recommend a different type of stocking with just 8 millimeters of compression, this fuzzy whale stocking. It's amazing for post-op. Patients really like it because it's easy to put on, and you don't get that local tourniquet effect that you can get with a the typical white compression stocking that everyone wants to use, that no patient wants to wear, but there's many surgeons say you can wear it. This is the way I've always done it. But if you don't pull it up just right, you'll get local tourniquet-like effects. It's very painful, very challenging to put on, even in the setting of no surgery. And so again, this is where we recommend a different type of stocking from. I use the one from the Edema Wear product. Patients really like it, and my physical therapist, who's also a CLT, she and I are kind of surprised about that patients really find it very helpful. So, in any event, I see everything you're saying, Emily, is what I've seen, and what I've been told. Oh, that's normal. That hematoma, it is what it is. And no, there's so many things to do. So I'll try to go through a couple of the other slides and get a sense of it. So again, the sodium by itself, high sodium intake, also impacts the immune system and potentially increases infection risk. And then again, we have some basic exercises. Just try to get 15 to 20 minutes of walking or exercise on a bike, or even just standing at the kitchen counter and just walking in place. Those are the kind of things that I recommend versus aggressive attempted strengthening. And then I got maybe 150 text messages and emails about this because everyone knows I'm interested in swelling. So this article just came out in the JBJS. This is one of our main orthopedic journals, the efficacy of diosmin in reducing lower extremity swelling. And everyone had said, Wickline, is this good? So I really, I've had to remind many of these colleagues that that's just one of the bioflavonoids in the MPFF, which has been studied extensively for the last 40 years or so, and that's what's recommended by multiple societies, AVLS, SVS, AVF, and so forth. And so, but again, I think the orthopedic surgeons, just by the volume of text and emails that I got, surgeons are seeing this problem, and they just don't know what to do about it. And they want something that's easy. And so again, this is why it's one of the recommendations. And
can I add something? It's just because recently with my friends from the American Venous Forum, we were doing the systematic review for all venoactive compounds and a post-thrombotic syndrome. And that remind me, there is a wonderful paper that I invite you. I will send it to you. This is a paper by a surgeon who, in the general surgery, and in two groups of heavy risk patients and less risk patients, used MPFF as an addition to anticoagulation, and had actually surprisingly great results, like the decrease, and it was randomized controlled study. And he had the decrease of the deep vein thrombosis and the pulmonary embolism in those patients. I will send you the paper because it's worth to thinking about it. And actually, I was always fascinated about this inflammation and thrombosis linked to this whole processes. And I was thinking that it could be a wonderful research with this kind of compounds to prove indeed that this is a safe and efficacious way of preventing thrombosis. Maybe indeed in the addition with the anticoagulants that we have now. And but as MPFF, it's really well tolerated and safe. So that could be something potentially very valuable.
So I'm on board. I think a number of surgeons, that again, all of my colleagues reached out to me when that paper got published. So I think many of us are looking for solutions. We recognize it, but again, it's just we're on this hamster wheel. and sometimes it's hard to get off the hamster wheel and kind of reevaluate some of this stuff. So, and they asked me, well, is this safe? I'm like, how long has this been studied? I mean, here you can see 1989, where MPFF versus diosmin was studied. So this is 40 years. So. Again, these are stockings. I talk about. I see also there should be I think there needs to be a perioperative stocking that's easier to put on that does the trick, and then a more long-term stocking that helps with patients. There's this longer-term swelling that no one's really talking about between, that most of the studies are 6 weeks, maybe 12 weeks. But we know that at 90 days, in 2015, an orthopedic colleague published, 12% persistent swelling still at 90 days post-op. So that's a substantial number. So I think patients probably need treatment for 6 to 9 months. And again, we talked about really correcting albumin deficiencies and so forth. And again, when you're in grade 2, that's where these patients need to no elective surgery. Let's get them down to at least a grade 1 and improve their risk profile. And I think one of the keys is education. So I have an entire booklet. It's actually 2 booklets now: pre-op education and the daily journal post-op. In the next 2 weeks, we're going to go live with selling this whole this booklet to patients anywhere in the world that want to have a better outcome and really wants to have their questions answered. Because unfortunately, like we talked about, many surgeons there's just not enough time to say everything you need to say. So the education is key to getting patients to buy into this whole swelling reduction concept. So there's things we can do in the pre-op holding area. We're now cooling the leg before surgery. Dr. Baldini presented this about a month ago over in Spain. And he took 50 patients, and 50 patients got this cooling compression device, and 50 patients didn't. And you can see they were able to measure some biomarkers, statistically better inflammation in the patients cooled pre-op. So the question is, should we be doing that pretty much for any surgery? Potentially. You can see the range of motion was better, again, statistically significant. So I really love this because it's stuff that we already have. It's pretty easy to implement. And you can see even the bone was colder. So that may help with bone ingrowth or press-fit implants. And then there's all these other information and other things that surgeons can do, which I think probably is outside the realm of this lecture and this podcast. But there's a whole bunch of other things that can be done. And again, we talked about the tourniquet. And for my surgeon colleagues who still want to use it, I challenge you to wear one. And then I'd love to see what your swelling looks like the next 2 days. I think it's going to be pretty substantial. So let me I'll scroll out of the intraoperative stuff because I think this is really more from an orthopedic standpoint. This study we showed with this you can see the right here, the middle line, 34%. That's the average swelling on day 7. And you can see with my control group, we were at about 26%, and then with this new wash, we already done to 22%. So this lower line is the lowest 10th decile of the swelling curves published by Dr. Brian Lloyd, and you can see we were able to consistently get patients down in that lowest 10% in that study. So again, using all of these interventions. And then in recovery area, there's a couple of things. We get that ice machine right back on with some compression. We keep the knee bent. We try to keep the blood pressure under control. And then what do we do? Again, the surgeon is like, okay, I'm heading home. My surgery day's done. But for the patient, this is when the swelling tsunami the seismic event just started and the wave's about to hit them, right? So what do we do that next 6 weeks to control their swelling? And again, that diet, sodium intake, the essential amino acids have been shown to reduce IL-6, TNF-alpha, compression stocking, and again, MPFF, and then extended TXA. I think we're going to hear a lot about this in multiple surgical venues. And then I've developed a specific therapy protocol and specific step count to help patients. And so again, amino acids have made a difference. And again, this is all in my mitigating the swelling tsunami. But let me just I want to remind you, most patients never get to 100. 50% of patients get 110 degrees or less. This is at week 10 or 12 post-op. This is what you can see at week 2 post-op. And again, you can see that special stocking I use for patients. This is the outcome that I think patients should be looking for and really deserve and can have if they control the swelling. This is pretty impressive. Again, the Academy 2018 textbook says by week 10 to 12, we hope to see 110 to 120 degrees. And this is at week 2. So again, I had this crazy step count, and this makes sense. If you sprain your ankle badly, John, do you get up and try to do a 90-minute workout the next day? No way, right? You would stay off it. You would go to you basically only put weight on it to go to the bathroom and get something to eat. And the rest of the time you'd be icing and elevating. And that's really what we're espousing. And really, patients really love. They always ask me, how much is too much? And so let me just show you. So here's a patient who walked too much. You can see his range of motion, 6 to 100. See, post-op, he walked all over the place. Here's surgery. He didn't listen to me. Typical man. But this woman, she got an A grade. You see what she did? She was busy pre-op too, day of surgery. Look how little she walked post-op. She did exactly what I told her. Look at her range of motion. Instead of 100 degrees, she got 117 degrees. So again, I think this is very achievable. And then, so let me just show you this. This is, I think, up here, 34%. That's what the best surgeons in the country are getting using a standard total knee approach. Go to physical therapy. Go, walk. Here's my initial 26%, so better. Here's the next study we did, 21%. We're now down to 15.6% swelling on post-op day 7. We are below the 10th decile. And you can see even the range is below the 10th decile. And this is what I think we can achieve with patients. And this is what I think is going to help reduce post-operative infection, manipulation, stiffness, and so forth. So I'll stop with the slides, and I don't think there's anything else amazing here to say. But at the end of the day, I think we can do a better job, and it's not just orthopedics. I think we can do this and really put this through all surgical disciplines. So let me stop my screen share. Hopefully everyone in the audience hasn't fallen asleep yet. And I'm happy to take some more questions.
At VitaSupport MD, we believe in creating the best bioflavonoid-based supplements to support your vitality. Bioflavonoids are found in abundance in nature and support excellent health and wellness. The demands and stresses being put on our bodies in these challenging times are unlike any we have seen before. Support your body with the flavonoids it needs to fight inflammation and oxidation. Unlike other products in the marketplace, VitaSupport MD dietary supplements use micronized flavonoids for optimal absorption and effectiveness. Micronization is an advanced process which creates an ultra-fine powder easily absorbed by the body. At VitaSupport MD, we are passionate about making your good health our life's work.
Compliment. Very beautiful lecture, even though I had some technical problem to join you. However, I see a lot of lipedema patients, and they tend to have problems post-operatively when they have total knee, because they start. So our approach is very similar to yours. We do the lipedema treatment prior to the surgery, including the nutrition and the exercise program for whatever time they have available. And then they have the surgery. And it seems like with the MPFF plus the pump treatment and cryotherapy, they tend to do much better. But it is challenging to do lipedema patients with total knee when they are more advanced, like stage 3 plus. The healing is prolonged.
Yes, I would completely agree with that. But But again, it's partly because what we're doing to them. We're doing the surgery, the trauma itself, and sometimes with a tourniquet, so the second trauma. And then we're asking them to go and do a 90-minute workout 3 times a week. Again, if you were in a car accident and you busted up your distal femur, you would be non-weight bearing for 12 weeks. Those patients do pretty well by week 2 or 3. Their swelling is gone down significantly. Their motion's coming along, and it's because we don't let them walk on it. And so this is the thinking that once you see it, it's hard to unsee it, right? Because it's been in front of our face the whole time.
Thank you. And I use also very light compression, and they tend to do much better. I use different compression than yours, but it seems like I'd like to take a copy of your compression because it seems to accommodate the configuration of the lower extremity, especially when they have much larger volume proximally.
Right. You saw that in my pictures there. Neither of those patients they're my size or bigger. So these were not small patients. The majority of my patients have a BMI about 36 to 37. So this, like I said, the high compliance rate is because it's easy to put on. It's breathable. I have them wear it 24/7 for about 3 weeks.
And a nice advice about this light compression, that if you want to increase a little bit the compression pressure, you could superpose 2 light, and
yes.
You will gain more power and less elasticity, which is good for the compression treatment.
Yeah, I've read some stuff about that. You have the under piece, and then you use the inelastic on top, right?
You can use whatsoever. Yeah, let's say that you have your compression with the 8 millimeter of mercury of pressure. You have 2 of them, one over the other, and you have in theory 16 millimeter, and you have less elasticity of the material, because when you superpose, actually you are gaining in the rigidity of this. Okay. And it's easy to put on because the 8 millimeter, there's no problem for patient to put it on.
Right.
I thought the subject of steps was fascinating and in many ways, I think, counterintuitive. In other words, it's always been our advice, especially, of course, one of the main concerns in post-total joint patient is going to be DVT formation because of inactivity and, too much bed rest and so on and so forth. So I can see where the attitude has been, encourage the patients to walk. So I'd like to hear some more of your thoughts on that and how you arrived at that, because it's, as I said, counterintuitive for most of us. And the other aspect of the walking is you would think that would stimulate the calf muscle pump and also stimulate lymphatic flow through activity and ambulation. So I thought that was really, really interesting, Andrew.
So if you look at this, I pulled up the education book. You can see this post-op day number 4. I want 750 steps per day or less. But if you look at this, there's this may be a hip. I can't tell. It looks like it's a hip. But in any event, it's I want patients to take 5 or 10 steps per hour every hour they're awake. So you're right. We do want to prevent blood clot. But how many surgeons have actually spent 90 minutes with their patient in a standard physical therapy session, post-op day 1 or post-op day 3 or 5? Not many of us, right? But when you do, you see them crying, and you see that they're trying to work hard, especially because you're there. They're trying to be tough, and but then what happens? How many surgeons have actually gone home with that patient? No one. I've had some of these patients stay with me. We do some patients, it was during COVID, and one of my patients, he was cash pay. He came from a distance. It was over Christmas, so he stayed in my house. And it's interesting, the thought processes of what happens, what patients think each hour post-op. But the most important thing I think is patients who've gone to organized therapy, they hurt so much, they don't move for the next 6 hours. And they get so much inflammation. Again, as Doctor was saying earlier, that whole inflammatory cascade may be the progenitor of this DVT, right? So if you can control the inflammation, you may get less risk. And again, I had them walk 5 or 10 steps per hour. It's not that I'm saying don't walk. It's just don't walk too much.
Yeah. And it's wonderful that you can give the range of motion that they should have, but not too much. That's I'm discovering it too. Although they in one moment we were talking with John about it, because we had some example of what so-called motivated patients,
right,
that want to recover, so they are like putting themselves, I'm doing those exercises, I'm doing this and this, and this is certainly not good at all.
Yeah, this is how I explain it to the patient. I'm gonna share this slide one more time again, because I think this is the key. Let's see, I gotta go screen share real quick. Sorry, everybody, bear with me. Okay, and share, and you should see this graph again. And so here's day 0, pre-op, this is day 0, and then day 7, right? And so I always tell patients, do you want the fastest recovery? Yes, I do, doc. So if you sprain your ankle badly, do you walk 90 minutes the next day to make it heal faster? No, I don't, doc. So why would you do it for a total knee? In fact, if you do, here's what's going to happen. You're going to be this person. You can see you're walking. You're trying to show off to me that first week what a great patient you are. Now you're up here at 46% swollen. Now this is the curve you're on for the next 3 to 6 months of your life. You just climbed Mount Everest. How long is it going to take to get off the summit? It's going to take a long time. Versus you can come over here and you just climbed one of the Adirondack small peaks, Bald Mountain, and the peak is only 15.6, right? And so you're going to come off that mountain much quicker. In fact, you're going to make it home for dinner because you paid attention, right? And so I think once you show this to the patients that you can be, again, the standard range is 22 to 46%, and you can beat that. And that's what patients want. I want to beat it. I want to do better, doc. And so as long as you can explain why it makes sense and show it graphically, this has been very helpful in my practice and other surgeons who've started to lecture about this to their patients, because this is how if you want compliance, you have to explain why it's important.
Yes, well, absolutely.
This is a fascinating thing. And again, I always learn something in the program. I learned a lot tonight, but this is the thing really sticking out for me, because I'm thinking to myself, now, first, my question to you is, do you think that the mechanism behind that increased edema is just the increased time with the limb in a dependent position and with the patient upright and ambulating?
So I think there's right now, I'm this fall at the Hip and Knee Society, I'm putting on a symposium. I think you guys may be interested in that. And that symposium is 30 plus ways to reduce perioperative swelling. Obviously the pre-op, the intra-op, right? But then post-op. And I think it's all of those pieces. I'll be honest, I don't know the biggest game changer, but I do think it's step count. And it's not doing that 90-minute workout. And then after that, it's icing and elevating, right? We know that when you ice, for every 1 degree, you reduce the temperature of a chemical system where chemical reactions are occurring. You reduce the chemical rate of reaction by 1/8. So if you can drop it 4 degrees, you just decreased it by 50%, the number of chemical reactions going on, this inflammatory cascade, right? And so I don't know what percentage is each. All I can say is that we're 60% lower, give or take, than the national average with top. These are top surgeons that did that paper.
But in decreasing the step count, what was your personal philosophy? What was your thinking? Why did you want to decrease it so the patient's not in a standing position, from the traumatic aspect of recurring injury by putting pressure on the joint? What was your thinking behind that? It's fascinating to me.
those step counts, I independently came up with that number, and at the same time, contemporaneously, Dr. Mandume Karina, who I'm doing another project with, he was using a technology device that measures range of motion and steps and so forth. He came up with, we had almost the exact same numbers. And what we found, at least in my data, I was able to show that once patients, that covers 90% of patients. Once patients go over that number, their range of motion went down, their opioid use went up, their pain scores went up. And he found the same thing. And so really, we both, we both shared the data with each other, and it was kind of eerie how similar they were. So I do think this is the answer. And again, it's a combination of dependency and again, just increasing the inflammatory response, I think.
Well, I think that's really fascinating and insightful. And what it brings to mind for me is kind of how we have to learn, unlearn, and relearn some things. I think that you and I trained in a period of time with, TED Stockings and SCDs pre and post-operatively, and everything was about DVT prevention, DVT, and, sub-Q heparin and Lovenox before orthopedic procedures and, major intra-abdominal procedures and so forth, because DVT became such a massive thing. And then it was get everybody up and ambulating and moving and out of bed. And, a mother has a baby and she should go home, the next day and get out of bed. And the idea of bed rest was considered massively antiquated. And I think for good reason. With excessive bed rest, we know that there's increased DVT. We know that with excessive bed rest, we're going to get, edema, posterior edema in the lungs, pulmonary edema settling to the back, leading to pneumonias and so on and so forth. In extreme cases of bed rest, decubitus ulceration in the sacrum and so on and so forth, all the pressure points. So there's a million good reasons to get patients up and going. But I'm thinking, based on what you're revealing here, Andy, is that like everything else, maybe you can go too far. Maybe up and at 'em and walking 10,000 steps after a massive joint replacement operation is too much. Maybe people do need some rest and relaxation and time for the body to heal after major surgical interventions. And maybe, we have gone too far in that up and at 'em and no rest for the weary and all of that stuff. So I think it's a fascinating discussion and a fascinating thing to look at, as you said, not only in orthopedic joint replacement, but in surgical recovery overall. I mean, you can go too far with things. How many of your patients, here's a discussion we've been having forever, and my father, whose picture is behind me on the wall there, who was a physician for 45 years, exercise is good. We know that. But how many of the patients, young patients that you're replacing knees and hips in, are because they overdid it? The extreme athletes with the marathoners and the 100-milers. So exercise is great, but excessive exercise can also wear out joints and cause cardiomyopathy and all kinds of things. So the balance, like everything else, the truth is probably somewhere in the middle of all of this.
I think moderation in all aspects of life is probably the answer.
Best.
And certainly what you mentioned about, bed rest in the hospital, the problem with the hospitals is that patients want to get out of bed and they feel good enough they could get up and move to the bed. But then the hospital's afraid that if they have a fall, now they're liable because they didn't have someone there to help them to the bathroom, right? And so I think that's where some of that created issues, right? Is the whole medical legal aspect. When patients are home, they're going to be safe at home, and the data shows that. But there's not this worry that the daughter's not worried that if mom goes to the bathroom that someone's going to sue her, right? And so that I think that's the problem with the hospital bed rest, and that's where we got into trouble, is because that worry from a legal standpoint.
Fascinating stuff. Well, your hour is gone and surpassed. Andrew, and you thought it was going to be way too much time, and we're just getting started. We're on the tip of the iceberg here, Monica. I
killed you with the slides. I'm sorry. But I think some of those slides are very helpful. That pre-op evaluation is the answer. I think that and that's something that everybody could implement pretty easily. And then again, just seeing that curve at the end and seeing that we're, over 50% reduction compared to what some of the best surgeons in the country are doing. That's substantial. And each of these things are additive, maybe 2% here, 3% here, 6% there. But my goodness, we could make such a huge impact in opioid usage. We've got many of my patients use very few pills, 3 pills, maybe 3 tramadol after joint replacement. I only prescribe 10. The state of Florida is still prescribing over 100 oxycodone for 90 days of care. So that, again, if we can look at this whole picture in a more multidisciplinary way, I think we're going to see better outcomes overall.
Yeah, I agree. And I think seeing, again, the patient as a living and complex organism made up of numerous systems. And we as surgeons sometimes focus on our piece of the puzzle as if it lives independently from the rest of the organism. And of course, I don't have to tease you about it, but orthopedic surgeons have been
I knew this was going.
famous for that, So, well, and it makes sense because it seems like a very mechanical part of the body. And you say, well, I'm just, fixing this joint. And so how could it possibly be related to this very complicated, inflammatory cascade and the thrombosis cascade and venous circulation? And certainly, as we all know, we've all had a massive education in the last 5 to 10 years about the lymphatic circulation that we basically neglected completely in our education, and it was poorly done. So now hey, this is a major physiological injury that's occurring. And then, as I've learned from my friends through this program, largely in the wound care world, don't just take care of the hole in the patient that you created as a surgeon, but take care of the whole patient. Mm-hmm. And that's exactly what you're doing with this philosophy, which is fantastic and amazing and really moving the field forward and moving the ball forward with a patient-centric point of view. And it helps the patient, it helps the surgeon, it helps the hospital, it helps the healthcare system. Everybody wins as a result of this excellent work that you're doing.
Well, again, I want to thank you all for inviting me. I realize that in orthopedic surgeons, we know what the heart's for. It pumps antibiotics to the bone. So that's about as close as we get to internal medicine typically. So, and thank you all for inviting me, and I encourage all of our listeners to look up the articles I referenced earlier. Those are open access, and it's really some eye-opening stuff. And I'm so thankful to Dr. Moline and Susie and Frank Aviles, Wendy Cole for helping me push me down this path, because there's so much more we can be doing. Thank you all.
And with wonderful result, as we could see on your patients.
Yeah, thank you. I'm very lucky. I got a great team here.
Thank you.
Have a good night.
I think with that, Paul, we're going to say goodnight quickly and efficiently.
You got it. Another great content-filled show. Reminder, visit our website, lymphcastnetwork.com. Hit us up on the podcast land or YouTube. Let's quickly go around the table and thank everybody from California. Got it right this time. Dr. Emily Eicher. Thank you, Dr. Eicher.
Thank you, Dr. Wickline. That was fantastic lecture and very insightful for all the patients. And thank you for a wonderful team.
All right. Thank you, Dr. Eicher. From Arizona, she moved back during the show, Dr. Monica Glavitsky. Thank you, Dr. Glavitsky, for everything. Think you for having me with you, team. And thank you, Dr. Wickline. I think it's a fascinating subject, and I'm so pleased by your mind openness and
implementation of all this rule into your practice. This is really a huge progress. Thank you.
Thank you, Dr. Glovetsky. Dr. Chubak, before I thank you, can you take a moment to thank our special guest?
Absolutely. Dr. Andrew Wickline, thank you for spending this hour with us. I knew that it would be illuminating. Hopefully our patients will get something out of listening to this. There are so many families, so many individuals affected by osteoarthritis and orthopedic joint problems from many different causes. So it's affecting and touching just about every American family. So someone is going to benefit from tonight's discussion. And hopefully, I'm sure many of our physicians, clinicians, therapists who are listening in have learned a lot. And I'm hoping that it's going to put orthopedic surgeons in touch with certified lymphedema therapists, physical therapists, occupational therapists, et cetera, to get our systems working better together and handing patients off to the proper people so they get the best of care, comprehensive care, holistic care. And we all thank you tremendously for the good work you're doing and being at the forefront of the wave of improved healthcare and not the tsunami of inflammation and swelling.
Thank you. And to the 1.5 million plus patients who have a joint replacement this year and each and more every year thereafter, at least until 2030, you owe it to yourself to learn about this, and or whether it's for yourself or your mother or your dad or brother or sister, because there's so much more that can be done both pre and surgery, during surgery, and after surgery. So you owe it to yourself to learn some more about this. And I will be having some educational materials for patients to review this in the later this month. Thank you again for having me.
All right. And thank you for being here. The gentleman who started this show, physician surgeon from New Jersey. He's also the founder and owner of Vital Support MD. They make and sell Vein Formula 1000 and Lymphatic Formula 1000. Dr. John A. Chubak. Thank you, Dr. Chubak, for everything.
Pleasure, Paul. Thanks to the great team, and thanks for our guests, and thanks for our listeners. Any questions, please email us, and thank you for all of your support. We're really, really shining light on an important subject of edema in all forms, and it affects many walks of life. So thank you, everybody. Thank you.
Yep, very well said. Again, our LymphCast show, it's been episode 52. We'll see you next time. Have a great evening.